The axillary lymph nodes. What about that? Those are the group of 20 to 40 nodes. They are classified into anterior, posterior, central, apical. Again, axillary lymph nodes, they are classified into anterior, posterior, central, and apical. What's the surgical classification? The surgical classification is done relative to the pectoralis minor muscle. Pectoralis minor, not major, minor muscle. Level 1, level 2, and level 3. Level 1 is the nodes below the pectoralis minor. Nodes below the pectoralis minor. Level 2, nodes behind the pectoralis minor. Nodes behind the pectoralis minor. Level 3, nodes between the upper border of pectoralis minor and lower border of the clavicle. That is apical nodes. So there are 3 levels: below pectoralis minor, behind pectoralis minor, between upper border of pectoralis minor and the clavicle. So what is this rotor's nodes? Rotor's nodes. Those are interpectoral nodes. They are found between pectoralis major and minor. They are inconstant in location and the number. Those are rotor's nodes. Then the lymphatic vessels. Efferent vessels from breast pass around the anterior axillary border. Efferent vessels from the breast, that's lymphatics which drain from the breast, pass around the anterior axillary border. They go through axillary fascia to reach the pectoral lymph nodes. Some may pass directly to the subscapular nodes. A few from the superior breast drain directly to the apical axillary nodes. Apical, do you remember? There's anterior, posterior, central, and apical. Some are interrupted by infraclavicular nodes or small interpectoral rotor's nodes. So regarding the lymphatic vessels, the efferent vessels from the breast pass around the anterior axillary border. They go through the axillary fascia to reach the pectoral lymph nodes. They can pass directly to apical or subscapular nodes. Some may be interrupted by rotor's nodes. Now, parasternal nodes. They drain medial and lateral breast regions, following the perforating branches of the internal thoracic artery. Parasternal nodes drain medial and lateral breast regions, following the perforating branches of the internal thoracic artery. Lymphatics may also drain laterally along the posterior intercostal arteries to reach the intercostal nodes. Lymphatics may also drain laterally along the posterior intercostal arteries to reach the intercostal nodes. Now we are done with axillary lymph nodes. The next part is axillary surgery in breast cancer. What's the purpose? The purpose is to dissect to assess for metastasis. Axillary lymph node dissection performed to assess for metastasis. So what's the significance of that? Metastasis in axillary nodes have a strong prognostic significance, and it may influence decisions on adjuvant therapy. Then, what are the complications of axillary surgery? The person can have pain, there can be seroma formation, there can be reduced arm mobility, there can be impaired sensation, and lymphedema. The axillary surgery, what are the complications we can have? Pain, seroma formation, third one, reduced arm mobility, impaired sensation, and lymphedema. Why? There's poor lymphatic drainage. That's why. After the surgery. The next part is we'll go for the sentinel node biopsy. Sentinel node biopsy is used for, what is the sentinel node? It's the first node draining the affected area. And it's surgically removed for detailed histopathological examination. Why? The sentinel lymph node, which drains first, helps to detect the metastasis in early stages. So how can we do the lymphatic mapping? It's important in staging early breast cancer. How? We give a radiolabeled colloid. It is injected into the subareolar tissue or peritumoral tissue. Also, vital blue dye is injected after anesthesia. Those two combines and locate the sentinel lymph nodes. Now, the innervation of the breast. There's sensory and sympathetic. Sensory and sympathetic. The primary innervation of the breast, anterior and lateral branches of the 4th to 6th intercostal nerves. So 4th, 5th and 6th intercostal nerves, they have the primary innervation about the breast. What about the nipple? Nipple is supplied by the anterior branch of the lateral cutaneous branch of T4. So nipple is basically supplied by T4. Sensory fibers in nipple form an extensive plexus. So why do we need an extensive plexus? They are free nerve endings. They have Meissner corpuscles for touch, Merkel disc endings for touch and pressure. Why is it essential? For suckling response, to signal the CNS that there's baby sucking on the nipple. Then the secretory function. It is controlled by the ovarian and hypophyseal hormones, not controlled by efferent motor fibers. This is an important point. Not controlled by efferent motor fibers. And the areola contains fewer sensory endings compared to the nipple. So areola has less sensory endings, least number of sensory endings. That's all for this video. Hope to see you in the next video. Thanks.